We'll now recognize gentleman from Virginia, the Vice Chair of the subcommittee, Mr. Griffith, for 5 minutes.
Thank you very much, Mr. Chairman. Dr. Gaynor, you touched on it a little bit earlier. A lot of us have concerns about having only basically 3 PBMs left in the market after all the mergers. And in fact, in 2015, a Judiciary Committee hearing, Professor Thomas Greene suggested it was time, just as you did, maybe for the FTC to take a look at the PBM market and the effects of consolidation. Even FDA Commissioner Scott Gottlieb has mentioned in that same hearing that he was concerned that PBMs were using their increased market power to prevent other market participants from growing or emerging. So I appreciate your comments this morning. And Mr. Chairman, I have and would ask unanimous consent to submit a letter I have received from the National Community Pharmacists Association outlining their concerns about PBM consolidation and the impact it is having on independent pharmacists.
Without objection.
Thank you, Mr. Chairman. Is there anything you wanted to expand on that before I move to the next subject, Dr. Gaynor? Well, thank you. I appreciate you answering those questions for Ms. DeGette. As often in some of these occasions, she and I tend to be going after the same area. Dr. Daphne, I have a merger that has just occurred. It's a little bit unusual because the concerns primarily were, can we keep the hospital systems afloat? 2 hospitals, East Tennessee, Southwest Virginia, merged. We're waiting to see if costs go up. People are very concerned about it. It just happened, finalized last month. They are now Ballad Health. I would love to see your article on the good merger so I can start looking at some of those numbers. But the concern there was one of the hospitals actually went under in one of the 2 systems. They're 2 fairly large systems by our standards in rural America that merged. I think they have 21 hospitals now. So they're a pretty good size. They're hoping they can stay afloat. That was our concern. It wasn't for financial reasons that they were going to make more money. It's can they survive? Any comments? Do you know anything about that merger?
If I may, I am familiar with that transaction. In fact, I authored a public comment on it, which may have been co-signed by my colleague here, Dr. Gaynor.
Were you pro or con?
I was concerned.
Okay.
Concerned because the hospitals sought and were granted, as you're aware, a certificate of public advantage because the federal enforcement authorities were concerned that there was effectively merger to monopoly in many of these areas. And when you say the hospitals did so because they were concerned that they would remain afloat, what goes off in my head is a bell that says price increase, price increase. How are you going to remain afloat unless you thought your cost reductions could be so substantial jointly than apart? You might be trying to use your stronger negotiating position to wrest higher prices from commercial payers, and that would make the economic environment less competitive. I'm aware the FTC did an extensive investigation, and if they had found those cost projections credible, I believe they wouldn't have tried to challenge the transaction. So I'm concerned.
Yeah. A number of my constituents are concerned, but we also want to make sure we have hospitals, because if you shut one down, it's not like there's another one right around the corner. It's usually around a mountain and down a mountain and up another mountain before you can get to the next hospital, and that creates concerns as well. But I appreciate that. Dr. Gaynor, you had something? And I want to Dr. Schulman.
May just add something. The use of certificates of public advantage to shield merging parties from antitrust scrutiny, I think, is not the right policy. I certainly understand the vulnerabilities and the concern over communities in these kinds of situations, but there are other ways to achieve these goals. And of course, as is well known, there is a failing firm defense for antitrust scrutiny, so that is taken into account. And the concerns that my colleague expressed certainly apply.
And I appreciate that. Dr. Schulman, I want to blow things up. I want you to think about it because I don't have time to get an answer per se, but I want you to think about ways we can help blow up and make the market more innovative. I really like that part of your statement and your concerns. Telemedicine, I think a big part of that's being held back by the CMS payment model and the fact that it takes an act of Congress to get some new payment arrangements. I think we have to take a look at the Stark Act. I have rural areas that are underserved where I have room in a nursing home, but they can't set up an opportunity there for somebody from the community to come in. I know we don't want them colluding on the nursing home patient, but we have space there that the community could use in an underserved area that we can't because we can't have telemedicine in the nursing home for a hospital an hour and a half away. Can you give us advice, and I'm out of time, but can you give us advice on what laws we need to change to make the system for reimbursement on CMS more efficient to recognizing that there are new ways to do this?
Yeah, absolutely. I think we have a limited amount of time, but the idea, when I got my board certificate, my licensure in North Carolina, they basically explicitly told me unless I saw the patient, I'd be in violation of the medical practice. So, that's not the world that we live in today. We need to experiment with these kinds of innovation models, see which ones work, and then deploy them.
Well, if you have language, I would be very interested in it, because I'd like to blow up the way we do the reimbursement so we can blow up the medical system and make costs come down. I yield back, Mr. Chairman.
Gentleman yields back. Chair will now recognize